So guys, we're talking about the complications of cholelithiasis. Complications of cholelithiasis, which is gallstones. Cholelithiasis. So we said that gallstones can complicate and then they can complicate into cholecystitis, and then they can also cause we are going to talk about these conditions, guys, ne? Just mentioning them now. Cholelithiasis. You can also, yes, acute cholangitis, very important. Acute cholangitis. When you get a patient who has got signs of obstructive jaundice, the next thing that the surgeon would want to know, are they having acute cholangitis? Because if they have acute cholangitis, it's an emergency. That stone needs to be removed there to allow biliary drainage to continue. So that obstruction needs to be removed urgently. But if it's obstructive jaundice without acute cholangitis, then that patient can be seen at the clinic. Yeah. Also can be gallstone, pancreatitis. Pancreatitis can be gallstone pancreatitis. Can be what they call Meritz syndrome, or gallstone ileus. So these are some of the complications that we can get from this guy. So it's very important. So what we want to talk about here is just the management of gallstones. How do we manage gallstones? And the management has got to do with how did the patient present. So so the presentation, like we said, it can be asymptomatic. It can be incidental finding. It can be the patient can be symptomatic. So a patient that is asymptomatic, there's nothing to do there. You don't know about that patient, that they have gallstones, and they've not come to you, so there's nothing much there to do. There's nothing actually to do there. But now when you talk about incidental can come in two forms. It can be an intra-op incidental, or it can be by imaging. Let's say you're looking for something else and then you send the patient to the sonographer to do an ultrasound, and then on the report it comes back that, okay, the patient's got gallstones. So those are the types. So what do we do? If it's an intra-op, this will not really depend on the patient, because the patient at that time might be under a GA, so they can't take consent. So two things can happen here. So the decision is going to depend on the surgeon. Is he depending on, do they have time? Does the anesthetist agree that we can continue and sort of like start another operation on top of another operation? So does the anesthetist agree? Is the anesthetist comfortable? Does he have all the necessary drugs to prolong the procedure, or whatever the case might be? So the anesthetist must be aware that there's an intra-op finding that we need also to look at. So it depends on the anesthetist and the surgeon. If the surgeon, the primary operation that they did, they are done with it, and then there's still time, they can go on and do the cholecystectomy. And also, if the primary surgery was not complicated, they managed to finish in time, there were no complications, then they can go on. So that's what can happen. Or they can close and say, guys, we've been on this abdomen, we've opened for a long time, so let's close, and then we're gonna see this patient again. maybe at the clinic, or maybe book another operation to do that's just the cholecystectomy. So yeah, but it would be nice to proceed and do cholecystectomy and spare the patient and save the patient from having another operation again. Okay, coming to imaging. So you were looking for something else, but then the sonographer tells you that, okay, there are gallstones in the bladder as well. So this one would depend. You will go and talk to your patient and say, okay, this is the finding. What do you think we should do? Maybe someone will say, okay, now let's wait and see if it's going to give me problems in the future, then I'll come in. That's option number one. Option number two, the patient might say, okay, no, if there's something wrong with me, please take it out. If you've seen something wrong, please take it out. I don't want to get sick in the future from this thing, so take it out. That's another option. So in other words, we can do expectant management here. Just wait, sit and expect. When the patient is having symptoms again, then we can proceed. But the patient that is symptomatic, they come in, they are sick. Analgesia using NSAIDs has proven to be very effective in this kind of patients. If they can't tolerate NSAIDs, then the opioids are the next group of analgesia that can be used. So, but the same patient can decide, okay, no, I want to have cholecystectomy. Then you can have a cholecystectomy. And also, someone else would say, no, give me painkillers and see if it's gonna trouble me again, if I'm gonna be sick again from this thing. Then they go home. But the study that was done in one of the European countries is that analgesia alone does help, and there were patients that were followed for about 2 years, and none of them were symptomatic within that 2 years of the initial presentation. And if someone is going to go home with a gallstone, you need to explain to them that they might come back with a cholecystitis. They might come back with the complications of hence they should come back the first time they are feeling unwell. They shouldn't wait. So that's that. So the ones that say, I want to have an operation, there are two possibilities there. You can do an open surgery, or you can do it laparoscopically. Obviously, open surgery has got more risk than the laparoscopic. They stay in the hospital longer. They usually need more analgesia than the ones that did it laparoscopically, and so the hospital stay and the chance of infection is much more because it's an open surgery. So one thing that I forgot, guys, with the presentation, so another feature of biliary colic, the patient might come back saying that, I get this pain especially after eating, especially after a fatty meal. Remember, after eating, especially something that has got that is fatty, that is full of fats, we need bile in order for us to absorb fats, breakdown of fats and absorption. So we need those. So the body will sense that, okay, now I've got I need to absorb fats. Then it's going to start to try and eject bile out of the gallbladder, so that the absorption of fats can take place. So a patient will complain of that, okay, this pain it's there, but it's worse when after eating. So that will be your biliary colic. So guys, we are gonna do acute cholecystitis, our next video on these biliary tree pathologies. I hope you enjoyed that. Yes, so the most important thing there, especially as a student, when someone asks you how do you manage gallstone, you need to sort of like make the one who's asking that you understand, be it the consultant or the medical officer, that okay, in terms of management, we've got three categories. We've got the asymptomatic patients, we've got the incidental, and then we've got the symptomatic. So with the symptomatic, these are the options. With the incidental, these are the options. With the asymptomatic, there's nothing there to do because it's the patient is asymptomatic, so there isn't anything to do there. So you need to classify it like that, and not just say operation, because it's not all of them that need to be operated. I hope you enjoyed that. So we're gonna do cholecystitis next. Thank you.